The following podcast is part of a certified educational activity. Chair's take on innovation in prostate cancer. Thoughts on new evidence. Access the entire activity and complete the post-test at peerview.com/UPY860. Downloadable slides and practice aids are also available.
Hello, and welcome to Innovation in Prostate Cancer, Thoughts on New Evidence. I'm Dr. William O. from the Tisch Cancer Institute and the Icahn School of Medicine at Mount Sinai. During this presentation, I'll focus on some of the recent evidence impacting management of prostate cancer across disease states, and also discuss some recent updates from the virtual ASCO conference in 2020. First, I'm going to talk about non-metastatic CRPC, where we stand on evidence for next-generation hormonal therapy. As we know, there are 3 randomized clinical trials, as noted on this slide, Spartan, Prosper, and Aramis, that looked at next-generation androgen-targeted therapies, apalutamide, enzalutamide, and darolutamide, respectively. And as you can see on this slide, the key eligibility for all 3 trials required the patients had non-metastatic, castration-resistant prostate cancer with a baseline PSA that was at least 2 nanograms per milliliter or greater, and a PSA doubling time of less than 10 months. The primary endpoint for these studies is shown here. It's metastasis-free survival, a new endpoint that the FDA approved. And you can see on each of these trials that there was a very significant improvement in MFS across Spartan, Prosper, and Aramis. In fact, there was a 24-month, a 22-month, and a 22-month MFS benefit across these 3 trials. And this represented very significant reductions in the risk of progression or death, 72%, 71%, and 59%. At ASCO this year, we heard about really the key endpoint, which is overall survival. And this was an important advance because we didn't necessarily know in these non-metastatic patients whether or not overall survival would in fact be improved in the setting of finding an MFS benefit. And that's because these patients were treated early before they developed metastasis, and that wasn't necessarily going to be true that they would develop an improvement in overall survival. But across all 3 trials, we saw at ASCO with 3 specific abstracts that there was in fact a hazard ratio of 0.78, 0.73, and 0.69 across the 3 trials, representing, as you can see, a very significant clinically meaningful difference in overall survival. And this really means despite the addition of subsequent life-prolonging therapies given to these patients, that they still benefited from early treatment in the non-metastatic setting by really reducing the risk of metastasis and subsequent death from cancer. So the clinical conclusions that I get out of these studies is shown on this slide. Apalutamide, enzalutamide, and darolutamide are all FDA approved for the treatment of patients with non-metastatic CRPC. And each of these 3 trials showed what I believe is a favorable risk-benefit ratio for patients with PSA doubling times less than 10 months. The median PSA doubling time in these studies, as a reminder, was about 4 months. So these are patients whose PSAs are doubling fairly quickly. We still don't know really what to do for patients whose PSAs are doubling much more slowly, because those patients may or may not get the same level of benefit. That's important to remember. And one of the issues about non-metastatic prostate cancer that's castration resistant is really that conventional imaging is what defines them as non-metastatic. That is bone scan and CT scan. What we are seeing now is that there are next generation imaging tests like PSMA PET that will be coming soon that actually can in fact pick up metastases in these patients. We kind of understand that this is really a flaw in our current ability to image small microscopic metastases. But in the meantime, these are important treatment options for our patients. The next area that I want to cover is metastatic castration-sensitive prostate cancer. Now, we've had a lot of issues about defining this category. It's really newly diagnosed metastatic patients. And you'll know that we sometimes call this hormone-sensitive prostate cancer, or HSPC, but I think that there's a general consensus that we should try to use some of the same language. So if we're using CRPC for castration-resistant, this represents castration-sensitive or newly diagnosed hormone-sensitive patients. Now, when patients present with metastatic disease, generally speaking, for over 70 years now, we've androgen deprived them. Initially with bilateral orchiectomy, but more recently with LHRH agonists and antagonists. And in fact, we have more and more data coming out about antagonists that may become a new standard of care. But that said, in the past 5 years, we've actually seen that there are other drugs, when added to androgen deprivation therapy, in fact, improve overall survival. And we first saw this with docetaxel chemotherapy, with the STAMPEDE trial and CHARTED studies. But in the past several years, we've seen updates with new next-generation AR-targeted therapies, specifically enzalutamide and apalutamide. And at ASCO last year, of course, we saw data for both ARCHES and ENZAMET, including a plenary session with ENZAMET, that showed that enzalutamide added to either standard of care and ADT, in fact, improved overall survival compared to standard of care alone. In addition, the TITAN study showed that apalutamide added to ADT improved overall survival compared to placebo. And again, the key eligibility here is noted in the slide below, the names of the trials, and that includes patients who have confirmed METs by bone scan, CT, or MRI, and good performance statuses, either 0 or 1. And just as a reminder, ARCHES was one of the key studies, the randomized trial that led to the approval of enzalutamide in the setting of MCSPC. And it had a primary endpoint of radiographic progression-free survival, shown here. And you can see that it was a very significant improvement in rPFS. In fact, the hazard ratio was 0.39 with a p-value that was less than 0.001. And you can see clinically, this is a meaningful difference in rPFS and contributes to the body of evidence that suggests that next-generation AR-targeted therapies, given at the time of diagnosis of metastatic disease, really significantly delays progression of cancer. Now, one of the ASCO presentations that we saw in the virtual meeting in 2020 was a post hoc analysis looking at outcomes in ARCHES based on the type of metastasis. And you can see on this Kaplan-Meier curve that patients with lymph node metastasis only actually had the best outcome. And that's not a huge surprise. We know that lymph node metastases tends to be associated with better outcomes. But you can also see that patients with bone metastasis only have an intermediate outcome, and those patients with visceral metastases or a combination of bone and lymph node metastases did the worst. And they had a significantly worse progression-free survival compared to patients with only lymph node metastases or only bone metastases. How do we use this kind of information? Well, I think these types of data in randomized studies confirm some of the prognostic information that we've known before. And over time, our goal really is to try to figure out if there are subsets of patients, for example, who should receive chemotherapy or patients who should receive AR-targeted therapy. So as we start to define clinical subsets, it will help us to understand not just prognostically who does better and who does worse, because that doesn't necessarily help us to make a decision in what drug to use, for example, but I think it will start to help whether we can define subsets that may be better suited, for example, to chemotherapy versus AR-targeted therapy. So one way to do that, of course, is to think more about biomarkers. And there was another ASCO abstract presented that looked at the issue of circulating tumor cells. Now, CTCs have been a little bit controversial over the past few years because I think even though they were tested and approved in prostate cancer, we have not been able to necessarily integrate it into the routine care of our patients. And part of the reason is that we actually have a very good and very cheap biomarker in PSA, and we've relied a lot on PSA as a way of measuring whether or not our treatments are working. So this was an interesting abstract that looked at a large randomized trial, SWOG 1216. These were patients with newly diagnosed metastatic castration-sensitive prostate cancer who were randomized to an LHRH agonist with bicalutamide as a standard of care, or Theranostics, which is a non-approved CYP17A inhibitor. But I think the important part of this study is shown really in the subsequent two figures. And you can see there that actually decreases in CTCs at 7 months strongly correlated with outcomes. And in fact, you can see that if a patient had a baseline CTC that was at least 5 or more, a significant percentage, over 75%, had actually progressed and died within 2 years. Whereas if they had undetectable CTCs at baseline, they only had a 40% chance of progressing or dying by 2 years. So it is an important prognostic piece of information, and I think that in the end, again, one of the questions that we don't know from studies like this is whether or not, for example, a patient with a high CTC count should, for example, receive chemotherapy, as one example. This study wasn't powered to ask or answer that question, but it starts to stratify patients with metastatic prostate cancer who might be better candidates, for example, for a more dose-intense approach or a more targeted approach with specific therapies. And I think we're going to have to start stratifying these patients biologically a little bit better. And even though CTC counts by themselves can be useful prognostically, I think in the future we'd like to actually see that CTCs might be used, for example, as a liquid biopsy and actually tell us which genes might be expressed in this type of cancer compared to a patient who has a different kind of cancer, so that we're not just using the counts per se, but perhaps the biology. So my clinical take-homes on MCSPC are shown on this slide. We know that abiraterone plus prednisone and docetaxel are standard upfront treatment options for MCSPC, but we also in the past year have 2 additional ones, apalutamide or enzalutamide. So we really now have 4 standard options for patients who present with metastatic CSPC. 3 of them are AR-targeted therapies and 1 of them is docetaxel chemotherapy. Now, one of the things that I didn't spend a lot of time talking about, but that more data will show up in our webcast, is really the idea that triple therapy with a novel hormone treatment plus docetaxel might be better. So far in Enzamet, we didn't really see that, and there are some ongoing clinical trials exploring that possibility, but right now there's no evidence that ADT plus chemo plus an AR-targeted therapy is better than either of those next-generation treatments alone. The other issue is really something I was focusing on the CTC question, which is that right now we still have troubles optimally sequencing treatment. If a patient comes in, he's 55 years old, and he has multiple bone mets and a PSA of 500, I start him on ADT, but what else should I add? Should I add abiraterone prednisone? Should I add apalutamide, enzalutamide, docetaxel? How do I know which one to give? Because in truth, we don't have any direct comparisons between these different options for these patients. So the answer to that question is, right now, any of the above are reasonable choices for those patients. And there are pluses and minuses to each of them, which we can certainly talk more about, and I think we're going to need more data in the next few years to kind of look at direct comparisons. Indirectly, they're all reasonable choices, and you're going to have to pick based on the side effect profile of each of those drugs and the patient's own preferences. Finally, I'm going to talk a little bit about MCRPC and what some recent evidence and approvals might be telling us about this disease state. Now, just as a reminder, we know MCRPC, or castration-resistant prostate cancer with metastasis, is kind of the final pathway by which prostate cancer becomes lethal. We know that prostate cancer has a very long natural history, 10 or more years in some patients, and yet if the patient hasn't had some other comorbidity or died of old age, in the end, unfortunately, MCRPC is the way in which cancer will progress and ultimately potentially be lethal to our patients. So this is the area where most drugs were first developed, including all of the drugs that we've already talked about, but also we know that the effect of drugs in those settings is more limited. And part of the reason for that is that these patients have already received many therapies and may have a decreased performance status. So the other important thing to remember is that as many of these treatments, like AR-targeted therapy or chemotherapy, have been moved earlier into the disease course, when patients develop MCRPC, we actually have fewer options now. So it's very important for us to really think about new drugs and new approaches to these patients, given the limited therapies that they may have once they've gone through some of the standard treatment options we've already talked about. So in the past year, we've heard about 3 important studies, which I'll be going over, looking at the value in this MCRPC setting of cabazitaxel chemotherapy in the CARD study. In PROfound study, we looked at olaparib versus physician choice, and in TRITON2, rucaparib monotherapy compared to what other options might be in patients with DNA damage repair mutations. And that was the key for all of these studies, is that they were really in second line or above MCRPC patients who had already received prior first line treatments, and certainly for the 2 Parp inhibitor studies, they had to have DNA damage repair mutations. So let me start with the CARD trial and discuss what this showed us. This was a clinical trial comparing cabazitaxel to either ABI or ENZA in patients who had already received ENZA or ABI. These were patients who had already received first-line AR-targeted therapy. They also received first-line docetaxel. So this is really third-line therapy. And if you look at the randomization, you can see that they were fairly well balanced. It was a pretty large study, over 150 patients. And the primary endpoint was rPFS, as you can see here, and there was a very significant benefit in favor of cabazitaxel compared to either ABI or ENZA given after the prior AR-targeted therapy was already used. 8 months versus 3.7 months, with a hazard ratio of 0.54 and a p-value that was quite significant. And if you actually look at overall survival, you can see that even in these relatively heavily pretreated patients, there was still an OS benefit with a hazard ratio of 0.64 and a p-value of 0.0078. This is why this paper was presented at ESMO, but also published in the New England Journal of Medicine, because in this setting of prior treated patients with chemotherapy and first-line AR-targeted therapy, the options are more limited. And you can see their survival is not as long as we'd like. They're living another year or so, but in fact we know that you can live longer with the addition of chemotherapy compared to giving a second round of AR-targeted therapy. But obviously we do need additional targets and new therapies besides chemotherapy and AR-targeted therapy. And this schematic is a very famous one by Hanahan and Weinberg, and it shows all the different ways in which we can target cancer, the known ways in which cancer grows, and the drugs that are used to block that growth. And I'm going to talk about two of the categories here that you see with the red arrows: Parp inhibitors and checkpoint inhibitors. So the first is really the whole field of Parp inhibitors and DNA damage repair. And we know in the past few years we've learned that about 23% of all mCRPCs harbor DNA repair alterations. That's higher than we thought. Many of these are BRCA2, as you can see on the right side of this graph, about half of those. But you can see that there's a whole host of other DNA damage repair mutations that may actually make these cancers more susceptible to drugs like platinum chemotherapy, but also Parp inhibitors. And you also see right below that pie chart, you can see that about half of those 23%, or about 12% of these patients, have germline alterations. Now, what does that mean? That means they've inherited it. It's in their DNA. Whereas the other half, or about 12%, have acquired mutations or somatic mutations. And it turns out that the drugs I'm about to talk about work in both situations, both somatic and germline. So it's very important to test both of these. The other thing that's important to know is that, in fact, age by itself, so we tend to think that, well, only young men might have a genetic mutation, and that's not necessarily true. And family history of prostate cancer. In fact, an interesting fact is that prostate cancer family history may be less predictive than the family history of breast cancer or ovarian cancer, because many of these BRCA mutations are found in women in the family. So the PROfound study was also presented at the European meetings and then subsequently again published in the New England Journal. And you can see the design here. It was mCRPC patients with disease progression on a prior next generation hormonal therapy like ABI or ENZA, and they had to have an alteration in at least one qualifying gene, which we'll be going over. And you can see that there were two categories that were randomized: either patients who had a BRCA1, BRCA2, or ATM mutation, which represented 245 patients, and there was a second cohort with some of the less common DNA damage or homologous recombination repair genes. Now, you're going to hear people talk about HRR genes or HRD genes or DDR genes. Unfortunately, people call these things by different names, but they're all representing the same thing. These are genes that normally repair DNA that are somehow damaged or altered or mutated and don't allow these cancers to basically repair themselves. And that's what these drugs seem to exploit. You can see that patients in PROfound were allowed to have had a previous taxane, but it wasn't required necessarily. And you can see that patients were also stratified by measurable disease. And they were randomized to either receive olaparib, 300 milligrams twice a day, which is an oral Parp inhibitor, or physician's choice. And the primary endpoint was, in fact, in cohort A, the patients with a DNA with BRCA1, BRCA2, or ATM mutations. And you can see here that there was a very significant difference in the rPFS in these groups. And in fact, if you look at 6 months, it was 22% versus 59% rPFS rates, and at 12 months, 28 versus 9 months. And the medians were also significant with a hazard ratio of 0.34, representing about almost a 70% difference in terms of progression rates, with a p-value that was highly significant. And in fact, the interim overall survival was also significantly favoring in cohort A the group receiving olaparib. You can see the hazard ratio is 0.64 with a p-value of 0.02. And even in the combination of cohort A and these less common mutations in cohort B, you can again see that there's a p-value that was significant, although nominally so, with a hazard ratio of 0.67. When you look at quality of life with these drugs, they are in fact well tolerated. And this was data presented at the ASCO virtual meeting. And you can see that patients who receive olaparib versus the control group, in fact, most of those patients had a significant improvement in health-related quality of life. And why would that be? Part of this is that these are late-stage patients. These are patients who are having symptoms from cancer. They're having progression, they're having pain, and any treatment that's effective is going to improve their quality of life. And that's what this seems to show. The other important thing about quality of life is, in fact, that you really can't have a drug that makes somebody feel really sick. If they feel really sick on the drug, then their quality of life may go down just from the side effects of the drug. So this slide seems to indicate that the ratio of improvement in quality of life from reducing symptoms of cancer compared to any side effects they may receive from the drug is very favorable in favor of using drugs like olaparib. This is showing this in a slightly different way, but again suggests that because the drug is delaying progression, particularly in bone, these patients are having less pain progression. And you can see that if you look at cohort A, you can see that the hazard ratio for pain progression was 0.44. It really suggests that these patients are less likely to develop progression, not just radiographically, but in their bones, and thus have less pain. And if you look at the combination of cohort A and B, again, these less common genetic mutations, you still see that effect, although a little bit less so. So based on all of this data, olaparib was in fact approved in May of 2020 for the treatment of patients with either pathogenic germline or somatic HRR mutations. Again, HRR is homologous recombination repair or DNA damage repair mutations with mCRPC, and these patients should have already received prior treatment with Enza or Abi and had progression. Around the same time, actually, we saw that another drug was also approved called rucaparib. This is also a Parp inhibitor, and it was based on this early study, the Triton 2 study. This was a phase 2 trial, again, you can see the list of genes at the bottom left that were eligible to go on this study, and you can see that these patients had to have mCRPC, had to have one of these mutations, had to have previously received an AR therapy, targeted therapy, and chemotherapy in this study. And they were treated in this phase 2 study with rucaparib at 600 milligrams twice a day. And this study shows the breakdown of the response rate by the gene mutation. And this is important because not all genes seem to respond to the same level. And you can see with rucaparib, the highest response rate, or ORR, overall response rate, was in the BRCA1/2 group. And you can see about 44% of the patients responded if they had a BRCA1 or 2 mutation. Whereas in the other groups, the response rate was less. In fact, the response rate was 0 in the CHEK2 and CDK12 groups, although those were very, very small numbers. So it remains to be seen whether some of these Parp inhibitors will work in some of these other mutations. But because of these differences in terms of the different genes, the BRCA1 and 2 were really the focus of this particular drug's approval, which also came in May. And based on this, the FDA did grant accelerated approval to rucaparib, but only in patients with germline or somatic BRCA1 and 2 mutations. So unlike olaparib, which has a broader label, in this case, you can only have a BRCA1 or 2 mutation in order to receive rucaparib. Again, they had to have received an AR targeted therapy, and in this study, because they all received taxanes, they had to have received a taxane. Now, there is a follow-up validation study called Triton-3. This is underway and currently recruiting patients with mCRPC with one of these genetic deficiencies. There are several other Parp inhibitors undergoing evaluation, niraparib and talazoparib, and you can see the trials listed here, a phase 2 and phase 3 with niraparib, as well as the same pattern with talazoparib. And over time, we're going to probably understand a little bit better, just like with the AR-targeted therapies, how different Parp inhibitors may be tolerated by our patients and their relative efficacy in different disease states and maybe with different mutations. So more to come on this area, but there are 2 approved Parp inhibitors and 2 that are still in active investigation. And finally, in the last few minutes, I'm going to talk about checkpoint inhibitors. Well, this audience and most of us who treat cancer patients know that, in fact, checkpoint inhibitors are approved in many, many different diseases, including lung cancer, including bladder cancer, including melanoma. Now, one of the diseases that has been left out of this is, of course, prostate cancer. And part of the reason is that the response rates in prostate cancer have not been particularly high. And I'll show you some of the data and why we're trying to figure out how to make this work better in prostate cancer. So Keynote 199 was a pembrolizumab trial, monotherapy, in mCRPC patients. And you can see they had to have received at least 1 prior AR therapy. They had to have received at least 1 prior chemotherapy, including docetaxel. And there were 2 cohorts here with PD-L1 positive or negative. There was another cohort, any PD-L1 with bone metastases. And there were 2 cohorts that had measurable disease or bone-only non-measurable disease. So it's a complicated 5-cohort study, but the bottom line is the goal was in Keynote 199 to see if there were specific subsets of men with prostate cancer, mCRPC, who might actually benefit more or less from pembrolizumab. And at least the cohort 4 and 5, which I just mentioned, these are 81 and 45 patients respectively. There was an update at ASCO just this past month that showed that about 12% of patients in cohort 4, and again, let me just remind you that cohort 4 is the RECIST measurable patients, had a response rate. Only 2 of those patients were complete responders, but 10% had a partial response. So this is not inactive therapy, and if you actually look at disease control rate, which is a combination of both stable disease and response, you can see about half of the patients had some disease control in cohort 4. And if you look at cohort 5, this is the patients with bone-only non-measurable disease, but in that population, you can again see that the disease control rate was about 50%. So what does this mean? I think it means that even pembrolizumab monotherapy in certain selected patients may actually be having, if not an actual shrinkage of cancer, may be stabilizing the cancer. And I think we really have to understand this area a little bit better. As I mentioned earlier, though, I think we recognize that with relatively low single-agent significant responses, we're probably going to have to combine immunotherapy with other drugs active in mCRPC. So Keynote 365 looked at pembrolizumab in combination with other known active drugs in prostate cancer. We talked about olaparib, and particularly in DNA damage repair or HRR mutant cancers, but in this study, patients of all comers were randomized to olaparib with pembrolizumab, and you can see that the efficacy measured, for example, by PSA response rate was modest, 9%, but the combination was fairly well tolerated. The rate of grade 3 to 5 events was actually fairly moderate, 35%, and patients had a median overall survival of about 14 months. Chemotherapy in cohort B was combined with pembrolizumab, and we know that chemotherapy is active in prostate cancer, and you can see that here. The response rate was reasonably good, 28%, and the patients had a median PFS of 8.3 months and a median OS of 20 months. So when you give an active drug like chemotherapy, certainly combining pembrolizumab seemed to be reasonably well tolerated, and most of the side effects are really related more to the chemotherapy than to the pembrolizumab. And in cohort C, pembro was combined with enzalutamide, and again, you see that the combination is non-cross-reactive in terms of side effects, and there was evidence of of disease control and also a respectable PFS and OS. So these are all updates, important updates about the safety of combining checkpoint inhibitors with known active drugs in prostate cancer, but I think it remains to be seen whether or not these are synergistic or additive, and again, I think selecting patients appropriately will be the most important. And at GU ASCO this year, this abstract got quite a bit of attention. This is Cosmic 021. This combined cabozantinib, 40 milligrams by mouth, with atezolizumab. And this was originally a phase 1 study with multiple disease states, but because there seemed to be some additional activity that was unexpected in prostate cancer, the CRPC cohort was actually expanded. And you can see from the waterfall plot that there actually was a very high response rate. In fact, the overall response rate was about 32 out of 44 patients. And in fact, the percentage of patients who responded with a CR was 6.8% and PR 25%, much higher than expected. And the disease control rate was about 80%. That's partly why this got a lot of attention, because we know that when cabozantinib alone was used in CRPC and atezolizumab was used alone in CRPC, the activity was not particularly good for either drug alone, but in combination they seem to have a greater than expected synergy. And in fact, although this study has to be really expanded in a proper phase 2 and subsequent trials, I think that there is clear evidence of activity that this dose is both safe and well tolerated, but also may have some increased efficacy, and I think more to come in this. And one of the most exciting areas, I'd say, in terms of novel therapies are the PSMA-targeted radionuclide therapies, and LU-177 PSMA-617 is probably the farthest along. There's a large randomized phase 3 study, the VISION study, that we're all waiting for the results of. But at ASCO this year, we saw the therapy study, and this was a phase 2 study of this LU PSMA treatment compared to cabazitaxel and MCRPC. And you can see it was a fairly large phase 2 study conducted out of Australia, and you can see that the randomization was either to cabazitaxel 20 milligrams for 10 cycles or LU-177 PSMA for 6 cycles. And the primary endpoint was PSA. One could argue that PSA is not always the most important measure of activity, but we all use this as one measure of anti-tumor activity. And actually the PSA response rate by 50% or greater reductions was double in the group that received LU-PSMA, 66 versus 37% with cabazitaxel. Now these patients were actually selected for enrollment because, in fact, you had to have a PSMA positive scan, and you also had to have that scan correlate with an FDG PET. And what that means is that a significant proportion of patients were actually excluded from the study if they didn't have a PSMA PET positive scan. But if you do have a PSMA positive PET scan, then in fact it seems to be pretty active to receive this treatment. It was also fairly well tolerated, and perhaps even better tolerated than chemotherapy. So just to finish, my take-home thoughts on MCRPC. Patients with MCRPC should receive a next-generation hormonal agent such as abiraterone or enzalutamide, and they should also receive chemotherapy with docetaxel. If they have received both of these treatments and have progressed, cabazitaxel is certainly a reasonable next-line strategy, and in the CARD trial we saw that it's clearly better than trying another AR-targeted therapy. There's no sense in continuing to give these patients multiple AR-targeted therapies compared to an effective drug like chemotherapy. Parp inhibitors have significant clinical value, and 2 Parp inhibitors were just approved in the past month for patients who have DNA damage repair mutations. So you should both be screening your patients for these with both germline and somatic tests, and if they do have a pathogenic mutation, particularly in BRCA2, but in any of the known DNA damage repair mutations, you should consider prescribing a Parp inhibitor. The 2 approved ones are olaparib and rucaparib, but more should be coming in the near future. Immunotherapy is a very intriguing treatment for prostate cancer, as it is for other diseases. We need more information to select the patients who are most likely to respond. Of course, if somebody has an MSI high tumor, they should get a pembrolizumab. But in most situations, we're gonna need to do more combination therapy and try to figure out who the best candidates for immunotherapy might be into the near future. And finally, PSMA, Theranostics, radionuclide therapy, however you want to call it, are really looking quite promising. I think we're going to see Lu-177 linked PSMA therapy, 617 in particular, come the soonest, but I think we're going to see other treatments coming down the pike that might in fact be targeted towards PSMA in the very near future. So just to conclude, I've been in this field for quite a long time, and I'm very excited that we're learning more and more about how to keep these patients alive longer, to improve their quality of life. And I think hopefully one day we'll start to cure some of these patients with metastatic disease. But in the meantime, the best we can do is control their cancer. And we see these different populations, the non-metastatic CRPC, the metastatic CSPC, and metastatic CRPC categories. And you can see that we're making progress in all of these areas. So thank you for joining me. I hope you found this program useful, and have a good night.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/UPY860. This activity is supported by independent educational grants from AstraZeneca, Exelixis Incorporated, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Merck & Company Incorporated.